Actually, it was a question that we had in the last years. I'm a transplant physician, so my really tough choice is when I have patients with ALL. When they go to transplant, I know that I want to offer them the best chance of cure, but I know that transplant also can end in a tragedy with a lot of toxicities. That's why I'm thinking, is 12 Cray what we're giving the right dose or it's not? When we go back to the studies, it goes back to the 1990s studies, where there were randomized studies, where they found that 12 Cray is enough. Actually, there were randomized study between 12 Cray and more than 12 Cray, and they found that 12 Cray is enough in order to reduce relapse and not to induce so much mortality. That's why it became the last years the TBI dose, the 12 Cray, the standard dose. And we will look also in the European Bone Marrow Transplantation Registry. We can see that actually we still use TBI, and in most of the cases we still use TBI 12 Cray, although the Germans, the GMAL study, showed that if you are more than 45 years of age, you induce so much toxicity, and that's why they recommended 8 Cray. So if 8 Cray is enough, and it doesn't have any impact to relapse, because if you reduce the dose, then you might have more relapse. That's why we try to answer these questions. Is this justified to give to ALL when we condition these patients, when we give these patients with ALL transplantation? Is it justified to give 12 Cray or 8 Cray, or to reduce the standard 12 Cray to 8 Cray? This was our question. And actually this was answered in a randomized study for AML, not for ALL. There was a randomized in AML that it saw indeed you can reduce the mortality or the toxicity by reducing the dose without having any impact of relapse. So it remained open for acute lymphoblastic leukemia. That's why we did in ABMT 2 studies. We looked at in our database, and we found that the last decade we transplanted about 8,000 patients with ALL in first complete remission. 65 of them received TBI, and then we looked exactly in the database, and we could find the patients that received 12 Cray and 8 Cray TBI. Of course, we saw that there is a connection between the TBI dose and age, as expected, and also we see that there's also a connection between TBI dose and hemo counterpart what we're giving. We give mostly 12 Cray with cyclophosphamide, and we give most 8 Cray with Fludarabine. That's why we made 2 studies. The first study is we compared only the patients that received TBI with Fludarabine. So 12 Cray TBI Fludarabine versus 8 Cray TBI Fludarabine, because we know cyclophosphamide has more antileukemic activity than Fludarabine, and we wanted to find the influence of the TBI dose on relapse, so we had to get rid of this hemo counterpart. Indeed, in this analysis, we had a lot of patients, and we found that reducing the dose has no impact on relapse. So we said it's okay, we can reduce from 12 Cray to 8 Cray. Of course, there was some, because of the retrospective study, there was some limitation on the study, especially this age connection that were there, although we did age-adjusted Cox multivariate analysis. And then we said we have to be more precise, and then we looked again at the database, and we make the match pair analysis, 12 Cray versus 8 Cray patients, and we try to have an exact match of these patients. Indeed, in the match pair analysis, we clearly could show, and we are trying now to write it and publish it, that reducing from 12 Cray to 8 Cray, you don't have any impact to relapse if you transplant the patient in complete remission 1, and but you have less 100-day transplant-related mortality with a hazard ratio of about 2, less overall mortality and hazard ratio about 1.7, with better leukemia-free survival, better overall survival, and better graft-versus-host relapse-free survival. So the data are there. Of course, there are limitations. There are retrospective data. We cannot also say anything about if it's preferential to use less Cray in patients which are MRD positive, because we don't have MRD data. And of course, we cannot comment anything about what is the correct thing to do if the patient's, let's say, below 25 years of age, because so few patients were that in our database, and we know that these young patients can tolerate the 12 Cray very well. I think the results are there, and they show indeed that if you have an adult patient, ALL, middle age, I don't know what young age is, middle age, 40 years of age, 50, 55, 60, and he's in first complete remission, you don't have to give 12 crates, just give 8 crate TBI, and because nowadays we have a lot of possibilities, first to bring the patients in first remission, transplant in a better condition, MRD negative with some immunotherapeutic agents, and also after transplant we have possibilities also to maintain the remission that we induce, or the remission, to maintain the remission that has the patient with multiple, many targets, immunotherapy targets or DLIs.